Yeah,
Yeah. So, welcome to day two of the event. I'm sure day one was very good, and day two promises to be even better. So, we kick off proceedings with Dr. Rishabh today. He is an associate psychiatrist in Brigham and Women's Faulkner Hospital and instructor in psychiatry in the Harvard Medical School. And he predominantly works in the areas that are at the interface of psychiatry and neurology medicine, and also schizophrenia, bipolar disorder, and particularly in psychopharmacology. He has published several peer reviewed papers on unusual clinical presentations of psychiatric disorders and unusual adverse effects of psychotropic drugs. So, unusual presentations, and if definitely we are in for a very exciting session on ketamine and esketamine in psychiatric disorders. So, something that I'm also keenly looking forward to. So, without much ado, over to you, Dr. Rishabh.
thank you so much for your kind introduction, Dr. Menon. It's an absolute pleasure to be here this evening, although it's very early morning for me here in Boston. So I want to talk about
But
ketamine and
it, can I
esketamine.
just say, do you want to share some slides?
I did actually. You're not
Yeah,
able to.
Dr. Rayner, we are able to view Dr. Rishabh's slides.
You are.
It,
Okay, that's
it,
great.
it, it might be some issue at your end. Okay,
Okay,
please,
that's my
yeah,
problem. Okay.
please go ahead, Dr. Rishabh.
So these two drugs basically, they have kind of revolutionized the treatment of treatment-resistant depression in modern psychiatry, and and they have kind of ushered in, the new age of psychedelic drugs as well. Before that, as you all may know, we were mainly using antidepressants, mostly serotonergic, working through serotonergic mechanisms and norepinephrine receptor intake, transporter uptake inhibitors, and those drugs had very, limited effectiveness. Even though they are quite safe, but they are not very effective, especially when there is treatment resistance, which tends to occur in the context of people having comorbid medical illnesses, metabolic syndrome, or neurologic diseases, substance use disorders, etc. And these drugs have enormous potential in terms of helping those patients who don't benefit from conventional antidepressants. So in this schematic, as you may notice, this is a molecule of esketamine, and then this is glutamate receptor, and how, it works on the glutamate receptor and can, reduce depression. And and as you can see in this another, slide, that there has been an exponential increase in the literature, in the research papers on esketamine in the last 6 years. uh, this is, I mean, I just use a keyword esketamine in PubMed, and you can see there are almost 1800 results, uh, and mostly in the last 6 years. So this buzz that has been created by esketamine and ketamine in the clinical and research communities in psychiatry has also been felt in the media. A lot of celebrities in the US, from TV, from, sports, from business, like they have like actively come out in support of ketamine and esketamine, like how it has helped them in their lives when they were very depressed. Some of these prominent people are Ryan Reynolds and Elon Musk and Michael Phelps, the glorious uh, Olympian, and but it also has, had its negative stories as well. As you may have, noticed in the news a few years ago, a very famous actor Matthew Perry, he died due to, ketamine overdose, which was prescribed to him by his psychiatrist for treating depression. Uh, a lot of clinics have mushroomed up in the US, which unfortunately are not very well regulated in the last few years. It is proposed that it is actually estimated that ketamine clinic economy is almost a $3 billion economy at this moment, and there are almost 3,000 plus ketamine clinics which have come up in the US in the last few years. So whether it is a miracle drug or is it a double-edged sword, we are gonna discuss that in detail today. Um, so first, let's talk about the history of, ketamine and esketamine and how we got where we are today. So ketamine actually is a very well-known anesthetic agent which was repurposed to use for treating major depression, and also is being explored for other psychiatric disorders. And esketamine is basically it's S enantiomer, which is the, so every basically molecule in the nature, which is chiral molecule, has two mirror images, which can have different biological properties. So esketamine is the left-sided image of in the ketamine mixture, and it was first synthesized in 1962 because phencyclidine, which was used as an anesthetic at that time, had very bad side effects. A lot of agitation and aggression used to happen with phencyclidine in the ORs. Uh, and then quickly it became approved by US FDA as an IV anesthetic agent in 1970. And then very soon people noticed that it could work as an antidepressant too, although the research on its antidepressant properties, was delayed by many decades. WHO also included it in its essential medicines list in 1985 because it's so valuable in the emergency rooms and in the, in the ORs. And then in 2000, again, it was found that the sub-anesthetic doses, low doses of ketamine can have rapid antidepressant effects in people with severe depression. And then finally, although it for many decades it was being used off-label to treat pain, only this year in August, US FDA finally gave its approval to ketamine for surgical pain management, and it can treat depressive symptoms within hours in some patients. And then for esketamine, the first trials kind of began in 2010 in people with treatment-resistant depression. It also works rapidly within hours to days. And then finally, in March of 2019, so 6 years ago, US FDA approved it as an intranasal preparation along with an oral antidepressant. That was a requirement in adults with treatment-resistant depression. And then European agency also followed the suit. And then a year later, it was approved, in people with depression who are also acutely suicidal. And then in this year, it was approved as a monotherapy. So you don't need to like add another antidepressant to start esketamine in somebody in the US. And then treatment-resistant depression was defined as people with depression who have failed two adequate antidepressant trials. And then there are many other, routes by which ketamine can be used. A lot besides IV route, it can be used as intramuscular, nasal, oral, rectal, subcutaneous, sublingual, and different routes require different doses because there are because of the change differences in their metabolism through different routes. Ketamine has a very high first pass metabolism. As a result, its oral absorption is very limited. So it's only up to 29% max compared to IV. And it is extensively metabolized by the liver by the CYP450 enzymes, which, as you may know, are also implicated in metabolism of many other psychotropic drugs, including antidepressants, SSRIs, TCAs, antipsychotics. Therefore, when you're using esketamine or ketamine, you must be careful with drug-drug interactions when people are on other medications as well. And there are several active metabolites of ketamine in the body, including norketamine and hydroxynorketamine, which actually is quite potent. And then its elimination half-life is very short in adults. It binds to NMDA receptor. Esketamine binds to NMDA receptor with much higher potency than the R-ketamine and overall the racemic ketamine. And that's why esketamine requires a smaller dose as compared to racemic ketamine for it to work. And the mean bioavailability of esketamine is around 50% with nasal spray administration. And how does it work? As I mentioned, it actually binds to NMDA receptors both in the receptor site and allosterically. It antagonizes the receptor, and it also then leads to AMPA receptor activation, which are other ion channel receptors, glutamate receptors subtype. And then this AMPA receptor activation triggers second messenger pathway, which then leads to neuroplastic changes downstream, which is responsible for rapid sustained antidepressant effects. There is also mixed evidence regarding whether ketamine has an opioid agonist role or not implicated in its antidepressant effect. It does activate mu, kappa, and delta opioid receptors, and it can also work as an analgesic in conjunction with opioid treatment. In fact, it actually works very synergistically because it reverses the opioid-induced respiratory depression. Now, in this schematic, I've highlighted, the mechanism of action of ketamine in detail. It's a very busy slide, so please bear with me. So as you may see, NMDA, I mean, the ketamine, it actually binds to the extrasynaptic GABA receptor, GABAergic interneurons, which are inhibitory. It inhibits the GABA neurons, and that as a result, there is increase in the glutamate release in the synapse, which then causes downstream changes, second messenger changes, leading to increase in the upregulation of mTOR complex. So mTOR is basically mammalian, uh, target of rapamycin, and that when that happens, there is upregulation of postsynaptic density 95, and it also basically increases uh, the expression of AMPA receptors on the neuronal synaptic surface, and then that also then secondarily increases the upregulation of the translation of BDNF, which is a neurotrophic factor, and that is believed to lead to antidepressant effects as well. And in addition, ketamine can reduce the firing of lateral habenula uh, neurons, which also confers its antidepressant effect. It can also bind to the mu opioid receptors on the neurons, and then in addition, it can basically you know can increase. It can also exert its effect through the uh, tra- uh, trans myosin kinase receptor B as well, by promoting the neuronal growth essentially. So that's how it basically works, and it's this mechanism is very unique compared to other antidepressants that we have in the market, and that as a result it basically shifts the balance between excitatory and inhibitory neurons in the brain towards excitatory. Um, and then in terms of esketamine, its efficacy and its safety has been established in multiple phase 3 trials and meta-analysis, mainly as an adjunct to SSRIs and SNRIs. However, a latest meta-analysis which came out this year, which had 87 studies included, provides a very sobering view actually. According to this meta-analysis, which was published in American Journal of Psychiatry, esketamine effectiveness is actually quite limited, and it starts waning off actually after 4 weeks of use, and this meta-analysis showed that it doesn't really have much of a anti-suicidal effect in the trials, and it also found a very concerning finding that there could be a possible withdrawal effect in patients. So basically, when you stop esketamine or ketamine in these patients, there is like a risk of suicidality in them. In fact, they found 6 patients in this meta-analysis who completed suicide when esketamine was stopped, and none of the patients in the placebo arm, had a completed suicide. So that was very concerning. And so the authors propose that esketamine probably does work like an opioid agonist, and some of the suicidal tendencies that it can trigger are similar to opioid withdrawal related suicidal ideation and behaviors, and overall discomfort that patient experience, that we know from substance use disorder literature. um, and then overall, like in terms of how esketamine is used, so it is available in the US as a nasal spray, which is covered by insurance companies. It's a 28 milligram esketamine per device, and each device can deliver 2 doses, and the maximum dose that is allowed is 84 milligrams in a patient. And that overall FDA approved schedule for esketamine is basically you can use it twice per week for 4 weeks, and then after that once weekly for 4 weeks, and then subsequently, depending on the response, you can either use it weekly or once every 2 weeks. And I don't know about how ketamine is delivered in India, and I definitely know that esketamine is not available in India and in much of the developing world. But in the US, esketamine is delivered in the clinics and the hospitals where patients will come in with a caregiver, because it is not offered when they come alone, because they can have like sad adverse effects and they may not be safe in terms of going home alone. and then they have to wait in the hospital for 2 hours after receiving esketamine because of the sedation and other possible, vital sign changes that can happen in them. And then they basically will put on music, or they are placed in a room. There are nurses and doctors who kind of check on them in between. Uh, that's how it is kind of delivered in the US. Um, and then what are its other psychiatric indications besides unipolar depression? So it can be used in bipolar depression. There are some studies on that, not a lot, but few. It is also being explored in anxiety disorder, like on whole spectrum, in PTSD, in obsessive compulsive disorder, in eating disorders, substance use disorders, namely alcohol, cocaine, and uh, opioid use disorder. And some studies have also used it in cannabis use disorder. It is also being used for chronic pain and chronic migraine as well. So multiple, potential indications for which it might get an FDA approval in the near future, and promising findings actually in all of these different disorders. But again, the studies that have been done are actually very small, and there is a lot of variability, especially when it comes to ketamine use in these conditions. Therefore, it is hard to make a strong case for using esketamine or ketamine in these disorders at this current time. Um, and then there was this very well publicized trial that was done, and by a clinician researcher at Brigham, where I work. It was published in NEJM. It was a very large study, which was a non-inferiority trial in which ketamine was compared with ECT in people who were coming to ECT clinics because their depression was so severe. Uh, so they received 3 weeks of ECT thrice a week or ketamine, and there were almost 200 patients in each arm. And for the primary outcome was a response to their treatment, which was defined as more than 50% reduction on a patient-rated depression scale. And it was found that 55% of patients in the ketamine arm had response, whereas only 41% patients in the ECT arm had the response. So they were able to basically demonstrate non-inferiority of ketamine to ECT in this landmark study. And it was found that ketamine was actually more tolerable than ECT, and both arms had similar improvement in patient-reported quality of life as well. So therefore, it was proposed that ketamine could be a good alternative to ECT in people who don't want ECT because of the stigma and because of logistical issues. However, there was a Swedish study that was done a year before, which actually found ketamine to be inferior to ECT, but that study was done in inpatient setting. And this study, the one that was done in Brigham, by the Brigham researcher published in NEJM, was done in outpatients. And they kind of defended their findings by saying that ECT typically responds. People typically respond well to ECT when they have depression with psychotic symptoms, and generally it's the elderly geriatric population that responds well to ECT. Whereas in this study, patients were mostly in their 40s, the one that was published in NEJM. So that was kind of one of the highlights of this debate. And then, as you can see in this slide, how ketamine was kind of non-inferior to ECT in this NEJM paper, and the MADRS score also actually reduced over time, not just the patient self-report score, although that was used as a primary outcome. Now, what are other routes of ketamine administration which are being explored in research? So all kinds actually. People are using oral ketamine because it's very difficult to give IV ketamine to patients. Plus, it's very expensive in US. Ketamine IV ketamine is not covered by insurance. It is not FDA approved. Therefore, patients have to pay out of pocket, and it can cost up to $900 per infusion. So therefore, people are exploring easier routes, cheaper routes. So tablets are being explored, lozenges are being explored. People are using subcutaneous ketamine so that patients can inject themselves. And then there are intramuscular ketamine, which is cheaper than the IV route for obvious reasons, because you need more expertise in insert in administering IV ketamine. And all these studies have actually shown very promising findings. But again, these are like small studies. As a result, we it's still like one cannot say with great confidence that all these non-IV routes are ready for prime time use in the clinics. Now, what are the adverse effects of these medications? So a lot of them actually sedation, but these are mostly short term. So they are self-limiting. They kind of go away within a matter of few hours after the use. So sedation, dissociation, which means that patients are kind of awake, and they can move their eyes, they can understand what is going on around them, but they are not able to respond to the sensory stimuli. That is why the term dissociation is used, and that's why ketamine and esketamine are called dissociative anesthetic agents. These drugs can cause dizziness, vertigo, therefore they can increase the risk of falls. If the patient is not supervised, they can ironically increase anxiety, because patients can feel very uncomfortable with these perceptual changes and cognitive changes. They can cause respiratory depression if used at high dose. They increase blood pressure. When with long-term use, especially with recreational ketamine use, people can develop very painful complication, ulcerative or interstitial cystitis, which is inflammation of the bladder. People can have blood in their urine because of that. Some people can rarely have syncope, which is a false reason. I actually have a patient who developed syncope with ketamine, and then US FDA has ensured that esketamine is monitored, its use is monitored strictly. So there is a REMS program in which patients have to enroll and clinics have to enroll to limit abuse potential, because the ketamine has abuse liability, and so has esketamine. And as I said, patient must be monitored for 2 hours. There is no antidote in case anybody overdoses on these drugs, so they have to be treated empirically. Luckily, these drugs don't prolong QT interval in patients, so that's a good thing. But patients must not engage in any hazardous activities which require mental alertness on the day when they receive this, which kind of limits their functioning for that day. And now, what are the contraindications? So FDA has mentioned three major contraindications. One is aneurysmal vascular disease, even if it is in the thoracic or abdominal aorta. But there is no guidelines on whether one should obtain neuroimaging before starting ketamine or esketamine, which was surprising for me. And then if there is a history of bleed in the brain, or if somebody is hypersensitive to esketamine or ketamine for obvious reasons. And also, its safety is not established in pregnancy and breastfeeding, so please don't use it in those settings. And also, we don't have safety data available in people who are on dialysis, and due to end stage kidney disease or people with severe liver disease. So please refrain from using it in those settings, or have an open, honest conversation with the patient about that. Now, in case of Indian experience where esketamine is not available, people have begun to use IV ketamine and oral ketamine. And there was a study from JIPMER by Dr. Menon's group. There have been studies from Andhra Pradesh and from a couple other centers which have found ketamine in both oral and IV routes to be effective, quite effective actually, and their rates are actually comparable to the Western data. But the studies are small and not rigorously done methodologically. Um, and this actually also tells us that other countries can kind of follow suit and can use ketamine in their patients, but obviously with caution. Now there is this debate in the literature on which is better. Is esketamine better or is ketamine better? So a meta-analysis was done very recently, I mean actually 4 years ago, in which they had 24 RCTs. No head-to-head trials have been done to this date. Large head-to-head trials have not been done comparing ketamine to esketamine. But in this meta-analysis, they found that ketamine was overall better in terms of response and remission rates, and in terms of lower dropout rates compared to esketamine. But if you look at the subgroup analysis, there was no significant difference between ketamine and esketamine in terms of whether the patients were treatment resistant or not. or whether they had major depression or bipolar depression. Um, the other limitations of this meta-analysis were, they only were like very short duration trials, just 4 to 8 weeks. And in this meta-analysis also, ketamine's effectiveness kind of superiority kind of started waning off at 4 weeks interval. Um, and these participants were mostly otherwise, free of comorbidities that we tend to see in the real world. So one must, take these findings with like a pinch of salt, basically. Now, in terms of pediatric use, like in children and adolescents, which is another major group, because depression tends to start early in life. Esketamine is not FDA approved for children and adolescents in the US for any psychiatric disorder. However, that has not stopped people from using it and trying to see, and exploring its benefits. And it has actually shown benefit, although these studies are also very small in size. But there is a lot of controversy because this unregulated clinics that have come up in the market are offering ketamine to teens, in an unregulated way, and we don't know, we have no safety data on its long-term effects on teenage brain, like if can that lead to neurotoxicity or cognitive impairment. Nobody really knows about it. Now there is another very interesting development in the field where people are using psychotherapy paired with ketamine or esketamine, which has shown a lot of promise in treating several psychiatric disorders. Again, not FDA approved, but it is being done. But there is also a lot of variation in the studies in terms of the methodology and on what route of ketamine is used, how frequently it is used, what psychotherapy modality is being used. It's all a hodgepodge of different things which is done, but it is showing promising results in various psychiatric disorders. Now, I'm going to conclude my talk by saying that ketamine and esketamine both have brought a novel approach to treat depression, especially treatment-resistant depression. They are safe in short term and have potentially wide indications in psychiatry, but we need to explore their role in special population groups, especially children and those with comorbid neurologic and medical illnesses. And ketamine assisted psychotherapy is pretty exciting approach as well. Uh, but we need studies on long-term safety and efficacy data uh, for both these drugs urgently. And we need head-to-head studies as well. We need to see which routes are better, which dose intervals are better, and we also need to see if there are other related drugs which are better in terms of side effect profile, which could be used and which could be cost effective. So with that, I will conclude my talk, and thank you so much for your attention. And I'm happy to take questions.
Yeah, thank you, Dr. Rishabh. I think that was an excellent overview, and thanks for sticking to time as well. An excellent overview of, you took us through the history of ketamine, the PK and PD of ketamine, the evidence for these conditions in various psychiatric disorders, the adverse effects, and particularly there, we also use ketamine in our center, and I also would like to emphasize that some of the side effects which Dr. Rishabh mentioned are seen only in long-term recreational users. I think that point needs to be highlighted about ulcerative cystitis and all, and the contraindications as well. And of course, the last meta-analysis was very interesting about ketamine versus esketamine because esketamine is very costly. Even when it is going to be eventually released in India, I think I'm not sure how much people can afford it as compared to ketamine, which is dirt cheap here. So, we actually are using ketamine, and I don't know how much the evidence is compelling enough for us to migrate to esketamine, given the cost and other factors. Anyhow, yeah, I have just one question before I open it to the audience, and it is based on based on I want to know from your experience that what we have noticed with ketamine is that some people do respond, some others do not.
Right.
There is a clear kind of a dichotomy there, and of course, we are trying to build our own experience with these molecules. But from your experience, have you found any pointers towards what kind of people, what kind of depression responds to ketamine, what kind of depressions don't respond to ketamine? Any leads in that area?
Right. So I would say there is also like a lot of placebo response that we see. A lot of people, with like personality disorder, comorbid, or people who have somatic, like somatization disorders, tend to gravitate, or people with substance use disorder history prior, they tend to gravitate more towards these treatments, and also because they are quite expensive, even in the US, because ketamine is not FDA approved, so not covered by insurance. So people like who are well-to-do are only the ones who are able to kind of receive it. Uh, but overall, I have seen like patients do get better, but the proportions that are mentioned in the studies, we don't see in the real world like that's those same numbers. In fact, in our center, I have seen patients like up to like 30 to 40% patients are responding, but that's just a response. The remission rates are very small, like not more than 20%, and even those are short lasting. So when you stop the drug, most patients tend to relapse very quickly within a matter of 3 to 6 months. So that's why it's a sobering story. Like we were hoping that it will be kind of a game changer. It can kind of get people out of funk. It can help them get out of the acute depression. But then they need something ongoing as well. You can't just rely on ketamine or esketamine to help them deal with their problem, with their psychiatric illness.
Thank you so much, Dr. Rishabh. I think we'll just take a question which is there in the chat window, which is actually allied to what we have been discussing so far, because the participant has asked, even though ketamine affects some of these, neurotropic factors, which could potentially improve
Right.
neuroplasticity and long-term response, still, why is the effect of ketamine short-lived in most studies? So I think that's a great question to ask, and would like to know your thoughts on that.
Right. It's definitely a wonderful question, and I think this is a question for which I don't have answer. This is something which we need to look into deeply. Like why people lose the effectiveness so quickly, like at the end of 4 weeks. And in terms of pharma-sponsored studies as affecting the results, I mean, uh, I don't think most studies that have been done on esketamine are pharma sponsored. They have been actually done because it is covered by insurance. So institutions are able to do these studies independently without any undue influence by pharma companies. Uh,
Yeah,
but
but Janssen would definitely like to have their ROIs.
yes, absolutely, because people may have like other vested interests, like they might have like their own ketamine clinics, right? Or they may have invested uh like money in those, or so in case of, I would say, like in case of ketamine treatments, I would actually take those results with more skepticism as opposed to esketamine results.
Yeah, and you have already answered the other question on ketamine nebulization in
Right,
depression, I
right. I
suppose.
did not
So,
come across any studies on nebulized route for ketamine, but yeah, I think that will be interesting as well.
Yeah, there are some case reports, in fact. They
Okay.
used nebulized ketamine at a dose of 2 milligram per kg body weight, and they found it to be effective. But it is limited to case report. I don't know whether it is translated into a large clinical studies.
Right. Yeah,
And
I could not find any like big studies, like any
yeah,
trials.
mostly limited to case reports and case series. And I'm not sure whether ketamine to be given directly in an undiluted form for nebulization, or there is some sort of mixing with normal saline or something else to make it diluted form and
Right,
to give it over 20 minutes. So this is something, because ketamine 2 milligram per kg body weight is somewhere close to 2 ml, or in Indian preparation it is a 50 ml per 50 mg per ml. So hardly it will correspond to 2 ml. How it can be given for over a period of 20 minutes in an undiluted form, that is again questionable. So it need to be evaluated further.
right, right.
If you are going for a nasal esketamine, then probably nebulization ketamine might be in a close similar route, might be having effective
Right.
route.
But that is just a spray, like that's not like a
And that is
nebulization.
not going to the respiratory tract. That is most of the intranasal.
Right, right. Then I
yeah,
see
there's
a couple,
another question in the chat window. You could perhaps take that up, Dr. Rishabh. We have a couple
of
of minutes.
course. Could that be due to lack of theoretical framework underlying the efficacy? I mean, I don't think we have a very good understanding, honestly, of how esketamine, ketamine work in the brain, right? Like there are many other mechanisms also that have been proposed, which I did not mention just for the sake of time. Uh, those could those could be reasons why if it loses its effectiveness. And then the next one is, in which patient would we prefer ketamine as an anesthetic agent in ECT in patient with depression for synergistic effect? Um, yeah, that's very interesting. So typically, like if you use it in ECT, right? ECT is gonna like induce a seizure, which will increase intracranial pressure, and ketamine also does that. So I don't think you would want to use ketamine as an anesthetic in ECT like that. I think that can be a little bit risky, especially if you don't even know whether the patient has like intracranial aneurysm or arteriovenous malformation. Like I think if you really want to do this, you must be very careful and take due precautions and at least get an imaging to kind of rule out any intracranial lesion in the brain which could increase pressure. uh, I have not seen any studies either in which ketamine was used like like as an anesthetic in ECT. Um, and also we don't really know whether ECT and ketamine combination simultaneously will be better than either treatment alone. But yeah, I think it's an interesting question for sure.
I would just add to that. I think it's very difficult to isolate the effects of ketamine when you give it as a anesthetic agent along with ECT, and many patients will have the ceiling effect in terms of ECT is already going to produce a lot of improvement. So how do you judge additional improvement due to it's going to be difficult even if you have a comparator arm.
I
So
think
yeah.
the only way would be like one group gets ECT ketamine, other gets ECT propofol, and but then
Hmm.
I think you will need a very large sample to
Yes,
discern
yes.
of
The
significant.
the ceiling effect will come into play. Yeah.
Yeah.
Dr. Ramakrishnan had a question, I think. Is this correct?
Yes,
Uh,
Dr. Ramakrishnan, over to you. And perhaps we can stop with that then.
You have to unmute.
You're not audible, Dr. Ramakrishnan. No, we can't hear you. You are unmute actually, but I'm not sure why we're not able to hear you. No, we can't hear you. Sometimes it happens when you are changing the headphones. Maybe just disconnect everything and speak into the system as such, may work.
Okay. How about now?
Yeah,
Yeah.
that's better. That's better.
Oh,
Yeah.
cool. Thank you. Okay. That was my question about the theological theoretical framework. Um, I just proposed a journal session at the APA, next year's APA. The thing which we are working on is what is the effect, therapeutic effect that we have noticed is from the dissociation effect of the ketamine, which is causing the benefits in our patients. So we started working on understanding how to reframe the idea of dissociation in theological terms. And so with lack of the framework, the continued improvement will be lost. That's what we started thinking about, and we are writing some papers about it. Any thoughts on that?
I mean, I
Is it-
think there was a lot of kind of discussion and kind of debate in the literature on whether ketamine's effectiveness is because it induces this dissociation, uh, and in which kind of people are able to kind of like see their depression in different light, like in a more acceptable light, similar to how how similar to how basically hallucinogenics are proposed to work. But there are also studies in which people have tried to basically block that dissociative effect, and there are also metabolites of ketamine which are being explored, which actually do not cause the dissociative effect, and
Hmm.
yet it works. Like for example, when you take ketamine orally, it tends to cause very little dissociation, as opposed to when it is given IV or nasally, and still those studies have shown positive results. So I'm not sure if that is the entire explanation.
Thank you,
But
thank you.
to your but to your point, people are actually using psychotherapy to pair with ketamine so that people can integrate that experience when they are having ketamine actively, and that has also found to have like very positive effect as well in patients. So I
Exactly.
think
I'll take.
you probably are like you definitely have a strong point there, but I just don't have enough basically knowledge about that, whether
Uh,
that is
can
essential or
can
not.
it can it
Yeah,
can it take just 20 seconds?
yeah, please, Dr. Ramakrishnan, we'll stop
Okay.
with that because we need to move on. Yeah.
Yeah, thank you. This happened after I took ketamine myself orally uh, with my supervisor, a professor in psychiatry, working on it. So with that, we came to that particular paper that we are case study. So it's going to be a case study. So I'll end there. The
Yeah.
effect was beautifully dissociative effect. I went through it personally. I could see that.
Sorry to say, we have to move on. And
Yeah.
Sujit, can you move on to the next speaker, please? Because if not, he's going
Yeah.
to. Okay.
Thank you, Dr. Rishabh, on behalf of all of us. Thank you
Thank you
for a
so
great
much.
Thank you,
presentation.
thank you, Dr.
Honored.
Thank you.
Rishabh.
Thank you.
Thank you, Dr. Vikas. Thank you, Dr. Rishabh. Now we are moving to the next session. Next session will be delivered by Professor Maheshwar Satpathy, and it will be chaired by Dr. Bipul Janardhan. So over to Dr. Bipul Janardhan for introducing the topic and the speaker.
Good evening, everybody. Thank you for giving me opportunity to introduce Professor Maheshwar Satpathy. He's the founder and CEO of the several respectful global organizations such as Global Health Forum, Global Brain, and the Mental Health Forum.